Welcome, and thank you for joining the program today, Coexisting with COVID, Finding a Way Forward. Dr. Karen Roush will be discussing the applications of SARS-CoV-2 Serological Assays for patient management in the hospital setting. With that, I'll turn the call over to Tony Casina, Ortho Clinical Diagnostics, our moderator today.
Hello, and thank you for joining us today for this program. My name is Tony Casina, and I'm your moderator for this Ortho On Demand session. As a member of the transfusion medicine community for more than 40 years, mainly focused on immunohematology and providing compatible blood, the recent times have brought the opportunity for me to learn even more about challenges that are ongoing with the SARS-CoV-2 pandemic. As states ease the restrictions in place during the pandemic, hospitals are resuming elective procedures, and there is continued need to protect patients and healthcare workers from the risk of contracting COVID-19. The goal of today's program is to share learnings from a hospital system who has implemented protocols to help achieve this goal. Dr. Karen Roush of the Methodist Health System in Dallas, Texas, will review current uses of antibody tests as well as current literature and share how they use the SARS-CoV-2 total antibody test together with PCR testing in a hospital setting for patient care. She will also review the progress to date. It's my pleasure to introduce Dr. Karen Roush. Dr. Roush is the Vice Chairman of the Department of Pathology for the Methodist Health System, Dallas, Texas. She serves as Medical Director at 3 of the hospitals in the system, including Medical Director of the Transplant Immunology Laboratory at the Methodist Dallas Medical Center. Dr. Roush also holds an MBA, which helps her in her numerous advisory and leadership roles, including chairing the Quality Performance Committee, as well as serving on medical executive committees, pharmacy and therapeutics committee, and antibiotic stewardship committees. She is the author of several books and book chapters on the topic of blood banking and transfusion medicine, in addition to the articles that have been published in peer-reviewed journals. One last note before we get started. The presentation lasts about 35 minutes and will be followed by a question and answer session. We will now begin the presentation. Dr. Roush.
Good afternoon, everyone. It's my pleasure to address you today regarding what we're doing at Methodist Health System in regards to antibody testing and some about PCR testing as well. So I've entitled this talk today, Coexisting with COVID, because we're not quite to the conquering COVID stage, although I feel like we'll get there in time. So since the topic today will be primarily about antibodies, the question is, should everyone have antibodies tested? Should anyone have antibodies tested? So I'm hoping at the end of this talk that you'll have some opinions that may differ from the ones that you have right now. I'm speaking from primarily Methodist Health System acute care facilities, and there are 4 of them. There are more than that, more hospitals than that in Methodist Health System, but I want to talk primarily about our 4 hospitals in the DFW or Dallas-Fort Worth Metroplex area in Texas. That area, it consists of 6.3 million people, and we have hospitals in 3 counties in that area that we serve. So with that background, we serve a lot of patients, and we want to make sure that we serve them in the best way that we can. So basically, I'm going to start with the punchline. The punchline being, I'm going to tell you what we're doing, and then I'm going to tell you how we got to that point, why we got to that point, and show you some data in terms of getting to that point that might make you think about things a little differently than you have been. I think I just skipped the slide. That was kind of important here. So our current state is all of the patients in the categories in this list now receive dual testing. When I talk about dual testing, I mean PCR testing and antibody testing. And the antibody testing that I'm talking about primarily today is total antibody test. And you'll see the reason that we're using total antibody test for the purposes that we're using the testing today. So we're looking at persons under investigation. That, as you well know, means people who have symptoms that we're trying to rule in or rule out a diagnosis of COVID. For the dual testing that we're doing at Methodist Health System, we've relatively recently implemented a dual testing process, meaning that in the beginning when we were testing these patients, we were only using PCR methods, and we really weren't using antibody testing to help define what their diagnosis was. The reason for that is because we had some evidence to suggest that they had COVID without adding that additional layer. But you'll see as we get on later in the talk about what some of the limitations of utilizing PCR alone are. So we have this symptomatic group of patients, and then we have inpatients that require procedures, but yet they don't appear to have COVID, at least on the surface. And we want to make sure that we're adequately characterizing what may be going on with them to protect both the patient and the healthcare worker. And then we have our outpatients who are coming in specifically for procedures or surgery that we have a little bit of time that we can take to see whether or not they may be appropriate for the surgical procedure they're having, as well as to make sure that they haven't been exposed to or have COVID that may not be showing, or these may be a group of asymptomatic patients throughout the course of an illness with COVID. So that's kind of our current state. We are currently doing dual testing, PCR plus total antibody testing with all of these groups. The future state that I've outlined below is we will eventually start testing all admitted patients, which we do not currently do today, but we are on the cusp of starting that. And actually, this slide says that we will be testing by dual testing methodology all of these patients, but we're going to probably have a softer rollout with that population of patients. So I've just highlighted what everyone knows to be true about COVID, which is I can say this right now, and it may change in 5 minutes. So we've got to be flexible to really go where the science goes and go where the reagents go and go what your hospital can afford to do. Because if your hospital cannot go on to be a going concern, you can't accomplish any of these things. So the goal really that I've alluded to is twofold. We need to protect our healthcare workers and we need to protect our patients. And there's multiple layers of what that means, protecting healthcare workers from getting infected with COVID, because if they're infected, they can't take adequate care of COVID patients. And we need to protect our patients by making sure that we're not doing something to them that would further advance the illnesses they come to see us for, and we don't want to do anything to them that's going to harm them. On the converse, we want to make sure that we're providing them with adequate care so that they get the surgeries that they need when they need them for both quality of life and quantity of life. We cannot keep pushing these things down the road. We need to get back into the OR, especially when a lot of elective surgeries were shut down around the nation. So those are the goals, and we at Methodist Health System, and probably your institution too, want to have a big, bright blue ribbon when it comes to the end of this. Did we do the best that we could with the science that we have in taking care of our healthcare workers and our patients? So really, it's what in the world has happened in the world since the end of last year. So basically, as everyone knows, this unknown virus comes out of China at the very end of last year. Really, at about December, we started hearing about this novel virus. And in the United States, we've had our first case reported in January. Maybe that was the first case, maybe it wasn't, but that is a very early time period and conservative estimate of when we started having cases in the United States. Probably some of the late winter and fall here, so October, November, December in China, maybe there were some cases that were unrecognized and very early cases then. But the whole world suddenly became aware of this. I'm kind of a news junkie, so I was paying attention to much of what was going on in the news, and I started talking about it to my colleagues. And not very long afterwards, nucleic acid amplification testing, or reverse transcriptase PCR, real-time PCR basically, was coming to the forefront. So I had a partner, and he and his wife, Zhao and Roush, had a small molecular lab. And so I would say, run it. They just published the whole genome of this new novel coronavirus. I think you should take a look at this and let's see what we can do with it. And so she's like, okay. And then the CDC posted on their website that they had actually developed a nucleic acid test that virtually anyone could order. At least that's what it looked like to my eye. And they were posting that. I'm like, Ronnie, you should order this test. And she said, I don't think they're going to send me this test. And I'm like, well, you can order it. Maybe they won't send it to you. And I think it's free. And, you know, everyone loves free. So she did, but she was somewhat skeptical as to whether or not she would get it. And then, as everyone knows, the PCR testing in the United States kind of hit a stopping point because one of the reagents was unfortunately contaminated. And that really slowed the rollout for what we could do. When the rest of the world really was forging ahead with their PCR testing, we had elected not to adopt the PCR testing that was going on in other countries. And I'm sure there were some very good reasons for that. And it is unfortunate that some of the reagents were contaminated, but the U.S. was quick to get back on its feet. I say quick. They've been judged somewhat harshly. But, you know, this whole pandemic has been going on for a length of time that some people can't get their house remodeled. So the expectations of what we want from the scientific community and our manufacturers and our hospitals have been very great. So I think in large part we have risen to the challenge of getting those things done. So eventually that little lab, and I call it the little lab that could, was one of the first labs in the DFW Metroplex to get the coronavirus PCR up and going, and has been supporting Methodist Health System and numerous other hospitals around our area since that time. In fact, I don't believe that Ronna and Joe have had a day off since sometime in the middle of March, and that speaks to their servant heart and basically their desire to protect our community and support the people who live here. And I know many of you are out there doing the same thing, and I really thank you for the dedication that you had to get this done. So literally, as soon as we started PCR testing, we found out that PCR testing actually wasn't picking up all of the people who were infected. Well, how did we know people were infected if the PCR testing wasn't picking it up? We found that out because PCR would pick this up on subsequent tests. And that was important because it really showed that you couldn't reliably depend on a single test. And the reasons for that were batted about by a number of people. I think initially many people thought that these tests were falsely negative, if you will, because the collection procedure wasn't very good. I am not one of the people who think that, really. And I should take a moment to say here that my opinions on my own, they may not necessarily reflect the opinions of Ortho Clinical Diagnostics or Methodist Health System. So if there are opinions not stated by or supported by peer-reviewed data, I want you to know they're my own, and so I'll take responsibility for those. But I don't really think that the manner in which collection occurs is making a huge impact on whether or not these tests are false positive or false negative. The reason being is that there's a lot of data that show that there's essential equivalence between a nasal swab versus a nasopharyngeal swab versus an oropharyngeal swab versus sputum. Now, some of these do have somewhat more sensitivity or likelihood of detection than others, but for the most part, these are relatively equivalent sorts of testing mechanisms. So, and the test itself is very sensitive if the virus is actually there. So a number of studies have suggested there's intermittent shedding. No one quite knows why this happens, but because it does happen, it does put some holes in what our gold standard test is, which is PCR. So it's the best that we have, but we're looking really at a surrogate marker or a surrogate sampling area for an internal infection. So once we had PCR up and going and the sensitivity and specificity of the PCR was acceptable, even though perhaps the identification of disease or a false positive predictive value and negative predictive value were variable because of the nature of the disease itself, antibody tests were rolling out. And really that cart got way ahead of the horse in terms of there were a lot of lateral flow immunoassays that were coming from overseas that had been developed in short order. And I think some of those were from good companies and some of those were from not as good companies. And for those of you who may not be familiar with what lateral flow immunoassays are, it basically looks like a pregnancy test. They can work very well if they're developed properly, but there were many on the market that gave very variable results. And I will say at that point in time, we here at Methodist Health System had one that has since been taken off of the list, or it's actually on a do not use list, not because the specificity suffered so much, but the sensitivity was problematic. So at that same time, which I was ecstatic about, FDA started tightening the screws and helping us, the scientific community in the U.S., evaluate which of these tests were good and which of them were not as good, so that it was difficult really to validate some of these tests because where are you going to find these samples? Being a blood banker, I was immediately drawn to, we're going to pull these things out of the freezer in the blood bank from before this pandemic hit. And we also, unfortunately, had a community pool that we already had very early on in Dallas that I had access to, and I basically asked these folks, can we test you for antibodies? And they said that we could. So we did validate, but not a large validation, but a validation that we could feel good about and comfortable with in terms of utilizing these tests. And I will say that our lateral flow immunoassay did validate very well, but again, that was a small pool and not big enough really to allow us to vet what the sensitivity and specificity claims were by the manufacturer. So FDA tightened those screws, but the scientific community and the public at large became very skeptical of what these results really meant, especially since the false positive rate in a low prevalence population, even with a good test, can lead to a number of false positive tests. I'll assert to you right now, we don't have a good sense of what the prevalence is right now, but it's much higher than when we started. And we're gathering data on a daily basis, literally at many places, to show that these are sensitive and specific tests when compared to the disease state and other evidence that we have to suggest that patients have COVID. So I am very happy to say that we had vitro analyzers in all of the 4 acute care facilities that we had, and that we had a lot of history with Ortho. We knew them to be a good, reputable company. We thought that a product that they brought would have good statistics to back it up, and we also knew them to be a company that if it did not, they would work on that, alert people when that needed to be done, and let us know. So we were ecstatic to see these sensitivities, specificities, and positive and negative predictive values. I'm going to see if I can turn on a laser pointer here without messing anything up. We'll see how skilled I am at this. And not as skilled as one would hope. But here we go. So the estimate of the performance for the sensitivity and specificity is 100%. Being a skeptic, 100% is probably, we're going to say, approaching 100%. And looking at these confidence intervals over here, they are also pretty good, up in the 90s and the high 90s. The positive predictive value at a prevalence of 5%, since those numbers are dependent upon knowing the prevalence, which we don't know, we're estimating basically, also at 100%. But you can see the positive predictive value dips down into the 80s in the confidence interval. But a very good test, one that we could be reliant upon. And if you utilize these in a higher prevalent population, or a population that you would suspect to be higher prevalent out of your total population, such as, like, I don't know, your person's under investigations that are showing symptoms for COVID without explanation for illness otherwise, is the perfect place to start this utilization. So the test became better. The antibody test became better. We got rid of some of the tests that were not as good. So now what do we do with this information that we have that we really can depend on? So initially these antibody tests were touted to be the holy grail to get to the other side of COVID. Moving through COVID, you're going to get a work passport, and we're going to know who's been infected with COVID, and these people are not going to be able to be infected again. and healthcare workers and first responders, we may be able to look and see who would be immune to this illness and be able to be put in the front line without jeopardizing their safety. Well, all of that was speculative and really has been rolled back in large part until we get more information about what we're dealing with this disease at large. So there are still talks about, could we have something like a work passport, such that work areas that may not lend themselves well to social distancing, like first responders. It's hard to be a first responder in social distance at the same time, and can we identify folks who may not be at risk? We're certainly not there yet, but there's much work going on to figure out if these antibodies can do something like that. So when you look to the CDC, which is what we do in the U.S. here to figure out the best thing to do, the conservative thing to do, the right thing to do, and you can point somewhere else and say, the CDC said we could do this. If you go to their website now, you'll see this advice about antibodies and what CDC recommends to do with those antibodies. They don't have the pretty picture, but I'll talk about the pretty picture, but they do have these words posted now. And basically, it's a very conservative, we don't know what this means. Until we know what antibodies mean in terms of reinfection, we need to social distance, we need to wear PPE like we've been instructed to do, and we should not utilize antibodies to determine if someone can work in a particular place without concern or worry of being infected or reinfected with SARS-CoV-2 leading to COVID-19 or their symptomatology. That's not very much advice about antibodies. There's a lot of room to wiggle around in here, and that's what this chasm was selected to represent with that. But antibody tests have skills, even outside of those return to work, you're protected. It allows us, a good test does, to determine seroprevalence. How prevalent has this disease been in the United States, or states within the United States, or communities within the United States, and allows epidemiological studies so we can figure out how this is spreading, where it has spread to, where it really hasn't been yet. And you can assess recent or past viral exposure for contact tracing. There are so many cases in the United States right now, the contact tracers are really overwhelmed. So looking at electronic methods to doing this, but also having antibody data where available is very helpful to know. Kind of you can follow the path of destruction in some cases, and the path of like asymptomatic infection in others. So screening of potential convalescent plasma donors is another way in which antibody testing can be utilized. And antibody test that I'm talking about, the total antibody test that is commercially available, IgG and IgM and some IgA standalone tests are also available, but these tests are not neutralizing antibody tests. And neutralizing antibodies mean that they block the virus from replicating or block the virus from getting somewhere where they can easily replicate. Those types of testing methods are not routinely available, so screening of potential convalescent plasma donors means that we can say antibodies are there, but we can't say exactly what those antibodies are doing or not doing. And what I want to focus on today is the aid in diagnosis in select scenarios, and that's where we think antibody testing really has had something to offer for our health system, our patients, and our healthcare workers. So the CDC agrees that we can utilize antibodies to help diagnose acutely infected patients. We cannot utilize antibodies as a standalone method to do that because these antibodies may mean that you previously had disease, but you don't now currently have it. But it does suggest that at some point you were exposed to illness. So basically that's what the CDC has on their website about whether or not you can utilize these. They say yes, but there are some caveats. You cannot use it as a standalone diagnosis. And this I wanted to bring out because this was an asterisk from my previous slide. And the Council of State and Territorial Epidemiologists, which is not a group of people that I'm very familiar with, but means a whole lot to people in the epidemiology and infectious disease world, they say that detection of specific antibody in serum, plasma, or whole blood indicates a new or recent infection provides presumptive laboratory evidence of COVID-19 illness. Now, that's going to be important when I talk about some of the things that we're going to talk about a little later in terms of how we ended up implementing what we did at our health system. One of the things that was very important to see published was this graph that's in the Journal of the American Medical Association. And basically, they looked at a lot of studies to come up with this nice, smoothed out graph of when antibodies come up, when they might be waning, and when you can detect them by PCR. And I'm going to try to show you, oh, look, there's my pointer. So this line here is important in terms of it divides symptom onset in these patients. So here you're incubating the virus, and here you start having symptoms. So, and these lines here are almost all of them are PCR detection in a variety of different sample types. And you come over here, and this is IgG and IgM when it would be able to be detected in most people. And it's after symptoms, sometime during the second week. Now, this is important for a couple of reasons when you look at this graph. IgG and IgM are coming up here at about the same time. For most other viruses that we've studied, IgM comes at first and IgG follows. But these are coming up at about the same time. The other thing to notice about this particular graph before we move on is that this is talking about patients who actually develop symptoms. And we know from many studies now that there are patients who remain asymptomatic or pre-symptomatic, and it's not always clear where in someone's infection, incubation, that we're sampling them. So this graph came from many studies that were specifically looking at symptomatic patients. So keep these things in mind when we get to some seminal papers that added some more value and insight into what antibodies and PCR together could do. So then we started seeing these reports about patients who underwent procedures that did not do well if they had COVID. In fact, one of the first papers, and this is in not a peer-reviewed kind of journal, and it was from a very low number of patients, but it found that the mortality rate, if you operated on someone in and around the time that they had COVID, was as high as 21%, which is a little scary to most of hospitals, patients, surgeons, anesthesiologists, anybody taking care of those types of patients. And then there was another journal article that essentially confirmed the same thing. These patients had high morbidity and high mortality if they were undergoing surgical procedures during the time that they had COVID, or if they had symptoms, or if they didn't have symptoms, which became a great concern as to how are we going to identify these. And then at about the same time, and honestly, this is from a perioperative statement about testing from a couple of surgical and anesthesiology groups that came after we at Methodist Health System were already utilizing dual testing in our algorithms. So basically, I'm going to read what they said. They said, currently, antibody testing does not have a role in perioperative screening and risk stratification. So right off the bat, we're like, uh-oh, because that is exactly what we're doing here, and that's how we're utilizing these tests. They went on to say antibodies develop in the second week of symptoms, and not all patients who are infected with SARS-CoV-2 develop detectable antibodies. So let's break that down. Antibodies develop in the second week of symptoms. Well, that's helpful if you have symptoms, but not as helpful if you don't develop symptoms. And if you don't know where in the infective process, you may be sampling someone who may not ever show symptoms, or the symptoms are so minor that you might only pick them up with something like a CT scan, for example. It is true that not all patients will develop antibodies after infection with COVID, but that does not negate the usefulness of a positive antibody test in those that do. And they went on to say, additionally, antibody tests have the potential of cross-reaction with other coronaviruses, resulting in false positive results. So I would say potentially that was true in the beginning when we had largely unregulated testing. Now we have very good antibody tests from many of the major manufacturers, so I think that you can rely upon those tests if the testing is done at a reputable laboratory. Virtually all of the hospitals in the U.S. now and our major reference laboratories are going to have tests that have high sensitivity and high specificity. And so they concluded that antibody testing should not be performed during a routine preoperative screening. Well, that did not change what our hospital was doing, because I think that I had repeated so many times while we were doing it that I really had won over some of the surgeons, anesthesiologists, administrators in terms of why we were doing what we were doing. I've kind of shamelessly stolen these slides from Orthoclinical Diagnostics about the sensitivity and specificity of their testing and what they've done to prove that it works well. And I would encourage you, if you start to do this, you need to make sure that you know what kind of data backs up the testing that you're using. Because if you don't know, it's hard for you to teach other people whose specialty may not be laboratory why they can rely and depend on these tests. And I'm very happy to say that I think Ortho has done a great job bringing their test to market, making sure that we had adequate supply of this test, and making sure that it did have high sensitivity and high specificity for us. So basically, they've shown that it's not cross-reactive. They've tested a number of samples to make sure that we weren't going to have false positives in who we were testing. And they've also tested a number of samples to make sure they could detect antibodies, all of which is fantastic. And so we've been able to utilize those with a great deal of confidence during the time that we have been testing. So I think I've gone over most of what the antibody sensitivity and specificity is provided by Orthoclinical Diagnostics, which is our major platform. And really, like I said earlier, I encourage you to know what your lab is doing and how reliant you can be upon the data that comes. This is jumping around just a little bit, but I wanted to highlight what the CDC is talking about now in terms of using mechanisms of not testing out once you have been diagnosed with COVID. This is going to become important a little further down when we talk about what this might mean in a surgical equivalent, if you will, as to whether or not it may be appropriate or inappropriate to utilize these CDC non-testing out strategies or symptom-based strategies. So basically what this says is if you have a positive COVID test, and 10 days after that positive COVID test, you haven't had fever for 24 hours, and your symptoms have been improving, you can be considered to be non-infectious for COVID. What this means is that the CDC and others have done testing to show that the coronavirus is not able to replicate in culture after this period of time for the vast majority of people. Now, they have come back to layer on if you have certain underlying immunosuppressive diseases, that time period should be lengthened to 20 days. And these things are changing. We're just having to follow the science as we uncover it. The science really doesn't change, but our understanding of the science is what changes. So basically, the assessment of this from the CDC that was on their website as late as July the 22nd, they do acknowledge that some people can shed virus, which is detectable by PCR, for up to 3 months after they were infected. This is problematic in a number of areas, and no one really knows what that means. Does that mean that there's an internal reservoir that is, shedding this virus, and so that if you get into that in a surgical fashion, that it may put the patient at risk for reactivation, it may put the healthcare worker at risk for reactivation? Is there a pool of dead virus, that there's some intermittent shedding? We don't quite know all the mechanics. We just don't know, but it's important to understand that this is happening. So going on to basically this seminal paper that Dr. Zhao and colleagues set out. Now, if you're putting together a puzzle, this is a border. These are border pieces of the puzzle. That's kind of what you have first. But one of the reasons that we started doing this in the beginning is because the sensitivity of PCR for the disease, not the sensitivity for the virus if present, because that sensitivity is very good, but in terms of its ability to predict whether or not someone had COVID, it's kind of not as great as you would hope on the first test. 67% total. But if you break it down a little bit into days after symptoms, almost all of this is from symptomatic testing. It starts at about 67% and then just goes down from there. Now, when you look at antibodies coupled with PCR testing, your ability to identify patients with disease goes up dramatically to about 99.4%. Again, these are symptomatic patients, so we're going to extrapolate that data to some other groups in just a bit. And you can see on the first, and this is 99.4% is overall. In the first week, this is not a very good strategy because most people won't have antibodies at that time, and their PCR test predictive value is about 67%. But it does go up to virtually 100% 15 days after symptomatology began. And here you can see just that they took these symptomatic patients and they started serially measuring PCR and antibodies on these patients to see about where they could figure out the sensitivity. And this is a heat map. Red, in this case, is good. And so once you got to about 10, 11, 12 days of symptoms, you could really reliably identify who had COVID in the right symptomatic milieu. So those were reasons why we did what we did, and this is how we kind of got to that point. So it really got kicked off. We had a fairly passionate surgeon. You know, surgeons are passionate just in general, but this one was particularly passionate. And he wanted to get back in the OR. This is at the period of time when elective surgeries were not ongoing. He wanted to get back into the OR, and he felt passionate about it because he felt like his patients were suffering in terms of they had surgeries that they needed to have for their quality of life, and some of them for quantity of life because it was diagnostic or for a variety of reasons we needed to get those ORs back up and going, not to mention which we're just going to have to figure out really how to keep our hospitals open, how to keep our healthcare workers employed, how to keep non-healthcare workers that are supporting our institutions employed as we figure out how to move forward. So he emailed me, and I had been thinking about a strategy, and so I emailed him back with that strategy, and he was supportive of it. And before I knew it, I found my room and myself in a room of masked surgeons, anesthesiologists, and administrators who honestly all came together to figure out a way we could implement dual testing so we could get as close to that 99% detection as we could for the safety of our patients and for the safety of our healthcare workers. So again, who are we testing? Person's under investigation, and he's going to be considered COVID positive. So if you have a positive PCR, you're COVID positive. If you have a positive antibody and symptoms, because to be considered a person under investigation, you have to have the right sort of exposure, you have to have symptoms. And so if you have positive antibodies with positive symptoms and you lack other reasons for having those COVID symptoms, you're going to be considered COVID positive if you haven't had a diagnosis, a laboratory diagnosis of COVID in the past. In the beginning, really no one had been exposed to COVID, so a positive antibody meant something except for the fact that we weren't quite sure with a low prevalence if some of these were false positives. But in the right symptomatic milieu, this population prevalence was pretty high, even in the beginning. So the other groups of patients are patients receiving procedures, are inpatients that were here like for a cholecystectomy because they had issues with their gallbladder. And then we have outpatients who basically don't need to be in the hospital, but they needed procedures so to be able to come into the hospital. From the beginning, I suspected perhaps that the inpatients and outpatients requiring elective procedures or other procedures, not necessarily elective, would have some differences in their COVID positivity. So we broke those patients out. And indeed, we did find that that was the case, and I'll show you that in just a bit. So basically, getting back to the OR started in early May, but in April we were planning to do this. And so we didn't take anybody to the dual testing stage until we had confirmed that they didn't have symptoms, that they didn't have exposures. And so those patients that did not have any of those things progressed to the dual testing platform. And so once we got there, it was the same kind of thing. If either one of those tests were positive, in the absence of a previous diagnosis of COVID, that would delay their surgery for 2 weeks, unless it was emergent. If it was emergent, these patients would go on to the OR, but they would be treated as if they were COVID positive, even if they only had positive antibodies. That was a fairly conservative measure, but we were very concerned about those high mortality and high morbidity rates. If both the tests were negative, of course, they would go on to the OR at that point in time. There were problems with this approach from a number of levels. We had to figure out how to get those specifically PCR tests back in time that they were meaningful in terms of you didn't want it too far away from the surgery, or people may contract COVID during that interim, but you didn't want it so close to the surgery that the surgical schedule was just in a constant state of upheaval. So we made that timing 48 to 72 hours. We extended it a little bit. We've had some patients that were indeterminate, so we need some time for repeat testing. And then we found that we had some issues with patients that were going to surgery on Monday or Tuesday, so we extended that time a little bit for the weekend. We have counseled patients to isolate after they had their COVID testing. Some of whom have been compliant about that and some of whom haven't, but it's really the best that we can do. Sometimes when you're problem solving, you find more problems. And we do know that we are delaying surgery in some patients that may have had an asymptomatic case in the past and may have positive antibodies now. And we've elected really to take on that conservative approach. But one of the things that we're thinking about doing may help make that a little bit better. And then we have these people who are persistently PCR positive. What do we do with them? Right now, we've been delaying them until they're negative. But we're considering utilizing some of the CDC recommendations for not utilizing a test-out strategy. So if you've been asymptomatic for the 2 weeks after you had your initial positive test, you would go to surgery. There's just a little concern that I have and others have, but you might not be able to extrapolate that, especially if there's an internal reservoir of virus that is producing what is not admittedly able to replicate in culture. But it could mean that IgA is taking that out once the shedding is going. I don't know if we have enough information to say even that we're clearing this virus. So we're talking about those sorts of problems right now and how we're going to deal with some of those. And so as this COVID evolves, we're going to have to revisit this, because once everyone or a lot of people have antibodies, it doesn't make sense necessarily to delay someone's surgery when antibodies are prevalent. But as antibodies are prevalent, testing is prevalent, and we should be able to note with some degree of certainty that patients have been exposed in the past, such that their antibodies would be potentially beneficial to their recovery and lack of morbidity and mortality after surgery. So basically, I've started advising people who ask me, perhaps you should get antibodies early, and then their 2-week time point starts clicking from positive antibodies. So if you do test someone for antibodies and they don't have antibodies, and then they come in for their pre-surgical screening and they do, that is a significant finding that you don't want to ignore. We did have something that helped bring a lot of our surgeons on board in the beginning. When we had a surgeon who did not have symptoms, but he wanted to be antibody tested, he went and got an antibody test from a reference laboratory, found it to be positive. The infectious disease physician said, really, you should be tested for COVID because you haven't had it before. And he did. He had a PCR nasal pharyngeal swab, and he was, in fact, positive. So he allowed us to spread that story which was helpful in showing the value of having an antibody test being positive at the same time that the PCR was also positive. So what we're going to delay the surgery. Then right now we're rescreening with the same methodology. Really, you don't need to rescreen your antibodies if they were positive, but to keep everyone on an algorithm that was constant and steady, we are. But we are actively talking about that, and that's going to evolve over time, as everything is with this. So what is the goal? The goal is to protect healthcare workers, and the goal is to protect our patients. And how are we going to recognize success? Well, the best way to recognize success is with data. We don't have that data yet because we need to compare our morbidity, mortality results after we gain enough patients in each one of these pools to compare to either others or our own data from patients who've had emergent surgeries that could not wait for the results of these tests. So that's really what we want to do. But I can tell you that our surgeons, anesthesiologists, administrators feel very good about what we're doing. We have not seen increased morbidity and mortality, and we have not seen increased outbreaks in our healthcare workers taking care of these patients. We had some byproducts of our results. We used EPIC, and basically we were able to look at these patient populations individually, and we could see that our persons under investigation had both high antibody testing percentages as well as PCR percentages, and we found that our outpatient preprocedural positives were lower. They were among the lowest. They started out at about 0.2, and today we're at about 3% positivity for those. Now, our numbers aren't high. We're testing between 100 and 150 a day, but those were patients that were unexpected, and for a while, the concurrent antibody positivity that we had at the same time was lower than our PCR test percent positivity, suggesting this was very early in our area, and now those numbers have come up. We did see that our inpatient procedures did have higher levels of both PCR positivity and antibody positivity, suggesting that while they didn't have typical COVID symptoms, it may be that their underlying disease processes were adversely impacted by an otherwise asymptomatic COVID infection. We are expecting additional tests to come out so that we can do quantitative testing. Virtually all of the testing out right now is qualitative. It's either there or it's not. A couple of tests have been approved by the FDA to do quantitative testing, and we're looking for something that could potentially serve as a surrogate for neutralization assays. And we're looking for something that we could look at our convalescent plasma donors more carefully. Can we figure out if a certain level of antibodies means that you do have long-term humoral immunity? Can we use these antibody tests to see if a vaccine works once there's one to the market in broad-scale use? And can we use antibodies to determine whether or not there are antibodies in the nasopharynx that may be prohibiting viral replication and which may be protecting us all from infection? That's all I have to tell you right now. I have so much more to tell you, but I'm going to stop here. I'm going to let you guys have some time for questions. I went a little bit over, but I'm going to be quick in answering those questions. So thank you for joining me, and I appreciate your time and attention.
Thank you, Dr. Roush, for your presentation and sharing your experience. We are now going to move to the interactive Q&A portion of our presentation. So, Dr. Roush, I do have the first question that has come in. What kind of training and communication plan was needed to implement the screening algorithm? And the follow-on question to that, did you experience resistance from the surgeons and other members of the OR teams? And if so, how did you overcome it?
Actually, the OR and the surgeons were very receptive to the dual testing strategy because they were very anxious to get back into the OR, and they were anxious to do it in a safe fashion for their patients. So initially, they helped to drive this. The educational components were a little overwhelming, but we had formed a task force. Our upper-level corporate administration formed a task force very early on that involved all 4 of our hospitals, And we rolled out much education through that task force, and it came from a single unified source, which was necessary. And in fact, in talking about scaling back some of the testing in terms of like the test out strategy versus the symptom-based strategy, we're having a little bit of resistance about scaling it back somewhat. So I think we've had the inverse of what most people would think would have happened.
Okay, thank you. Another question that has come in, can you speak about the outcomes you're seeing post-surgery in relationship to those individuals that have been tested and went through this algorithm?
So I would say we don't have any hard data about that yet, except to say that our morbidity and mortality appears to be very similar to what it was before COVID. We certainly have, like I'm sure patients in your hospitals have had as well, patients that did not get COVID testing, that ultimately we either knew they were COVID positive or they turned out to be COVID positive, that we have performed surgical procedures on those patients as well. So we're looking closely to see what their morbidity and mortality is, but even those patients don't seem to have fared quite as poorly as one would have expected from the two publications that I referenced. But certainly from the perspective of those patients that went through the screening process, we feel very good about those. And I queried our chief medical officers for the 4 hospitals to see their general sense of what the surgery groups there thought about their outcomes, and they were very positive and really didn't seem to feel that there was any difference in what was pre-COVID versus now. So I'm encouraged by that, but we really need to crunch that data. There's so much data that we can crunch on this so that we can be definitive in what our outcomes are.
Okay, thank you. We are starting to hear about COVID-19 antigen testing. Could you envision the antigen testing supplanting the PCR testing in your algorithm?
Well, it's funny that you ask. We have not implemented antigen testing at Methodist Health System yet, but we are in the process of doing so. I think antigen testing can be a very powerful tool if used in the right scenarios, which, because antigen testing is not as sensitive as PCR, it's important to combine that test in patients that have symptoms. Depending on what you're going to try to do with them, that's its greatest utility is patients that have symptoms. So we are going to employ, if we can get our hands on some of those, since the government really is deploying a lot of that antigen testing reagent to nursing homes throughout the U.S., but we're going to begin utilizing that test on symptomatic patients that are coming into our emergency department. It's helpful because it's very fast. So if it's positive, that is a good test that you can rely upon to say, yes, this is COVID. It doesn't mean confirmatory testing per se, although in our state, these are considered probable cases, not confirmed, but we will not be confirming those with PCR. Now, the inverse is not true. If there's a negative, that really does need to be confirmed with a PCR or a more sensitive test. So that's what our algorithm will be. We're also toying with utilizing the antigen test initially, at least, for patients that we are not testing at all right now. Because if we can pick up even a few of those, that may be helpful. And even in an asymptomatic population, what the antigen test does tell you, while being less sensitive than PCR, is there is a goodly amount of virus present. So you may be talking about dividing some patients into categories where there's a lot of virus that they're shedding versus not as much virus that they're shedding. So the short answer is we're not using antigen testing yet. We are going to deploy it and rely on it primarily in our symptomatic population of patients. It has less utility in patients that are asymptomatic.
Okay, thank you. This one comes from a small rural hospital. As a laboratorian, how would the dual testing algorithm be beneficial in a clinic emergency room setting that is mainly interested in acute infections and not necessarily preoperative. We currently have antibody testing, but physicians are unsure of how to apply it.
So that raises an interesting question, because if you're in a rural hospital setting, you may not have quick access to PCR testing. One of the things that we talked about in the beginning of the pandemic is how we can utilize antibody testing, which is very rapid. We have it at all of our facilities. We could not be more pleased with the turnaround time and the results that we get with that test. So we thought about implementing the antibody test in conjunction with symptomatology to define a diagnosis. Now, mind you, that is not utilizing antibodies as a sole source. It's utilizing antibodies in a defined symptomatic cascade, where you probably would or definitely would want to send off a PCR test for some confirmation. But that is one way you can get some very good information. Now, the pieces of information you need to know now, since we've had this a few months, is, has this patient been exposed with their symptoms? Have they had COVID before? And if you know those pieces of information, the right symptomatology, excluding other diagnoses, and having positive antibody tests, all of these things, the surrounding evidence, increases the likelihood that you are dealing with a COVID positive patient, and they should be treated as such.
Okay, thank you. Do you believe that the presence of IgM and IgG at the same time is reflective of a truer positive test versus just IgM reactivity, which may indicate a false positive test? Is that comment on that?
I don't really know the answer to that question. I do know that in the fashion that we're utilizing the test right now, the total antibody test is more sensitive to the presence of antibodies. And that's what we're trying to get to, is like a diagnosis. When we're talking about what this might mean in terms of testing these alone, I don't think there's a lot of utility in testing IgM and IgG one without the other. I think you would need really both of those. But the IgM test in general seems to be more problematic with its false positivity rate. So I really think you have to be careful in looking at any of these tests by themselves. IgG, on the other hand, certainly, to me, almost has more utility than IgM, because it's got the whole spectrum of illness. If you have a patient that has a good history, and especially know if they have had a positive laboratory test before, IgG is definitely the way to go. But running both of those tests concurrently, I'm not sure adds much more value than doing a total antibody test. And I've had to do a lot of fast talking, if you will, to convince my surgeons and others of that, because they're like, when are we going to get IgG? This doesn't tell us anything. I'm like, well, it does tell you definitely some things that are important. And I spend a lot of time repeating myself, which I think is fine. Surgeons, anesthesiologists, administrators, they're busy. They don't know what we know. And sometimes I'm repeating myself, and I'm like, I'm going to go look that up and make sure it's still correct, because things change so frequently. I'm a big fan right now of the total antibody test because of the sensitivity and still the relatively low prevalence of, or at least what we think the prevalence is, of disease in our area.
Okay, thank you. That one plays pretty quickly into the next one. Did you have to overcome a lot of confusion about the efficacy of antibody testing because of what was in the news about antibody, the quality of antibody testing? Yes,
Definitely. And I've just done a lot of preaching, just like I was talking about earlier, knowing the data for the antibody test that you're using. Make sure you know what antibody test you're using, who developed it, what their statistics are. These are important things for you to be able to show confidence to the people that you're working with in your facilities. If you say, I don't know what antibody tests we're using, I don't know what their statistics are, that does not help the confusion. It increases confusion. So make sure you know what antibody tests you're using and be ready to talk about it on a moment's notice, because I've gotten a lot of questions about antibodies and other things, and I'm sure you guys will too. And it just, knowledge is power, and make sure that you're willing to follow the science. And the science, you know, the breadcrumbs have gone off the path. You need to get back to where the science is. So be prepared to change and flexible, and just make sure you know what you're talking about.
Okay, thank you. I'm going to go with one more question. This relates to when a vaccine does become available, do you anticipate post-vaccination testing for antibody response? And I'll add a little bit more to this. How would you anticipate that would affect your current protocol when the vaccine does become available?
I think for a little while we will see some post-vaccination testing, because it's not going to be very clear how long these vaccinations will produce measurable antibody levels. I think that for our algorithm, we're going to really have to pay good attention to where we are with that vaccination. Initially, most people won't have access. That'll probably be a question on our pre-screening. Have you had a vaccine? That's going to obviously negate the usefulness of antibodies in terms of predicting disease. We're hopeful that it will mean that if you have antibodies after a vaccine, that you won't get disease. So I think for a while to come, we'll utilize the same algorithm that we have. And once we know about how vaccination will impact and prevent disease and how long those might last, we'll probably be able to scale back that portion of our antibody testing.
Okay, thank you, Dr. Roush. We are now coming to the close of the session. Thank you, Dr. Roush, for sharing your expertise and your experience with all of us, and for answering the questions posed by today's audience. To all of our participants, thank you for taking the time to join us and for your questions in today's event. We will address unanswered questions via email. We recorded today's presentation and will provide all registrants a link to the recording next week. We hope you will join us for our next Ortho On Demand program on September 23rd. Dr. Lisa Thiel of the Mayo Clinic and Dr. Neil Anderson of the Barnes-Jewish Hospital in St. Louis will present the program entitled "You've Been Asked to Implement SARS-CoV Antibody Testing, What You Need to Know," in which they will be reviewing the CAP guidelines for implementing SARS-CoV-2 antibody tests. With that, thank you. At Ortho Clinical Diagnostics, our focus is on improving lives through diagnostics, because we believe every test is a life. We look forward to partnering with you today and tomorrow. Stay healthy and safe.